Welcome, everybody. It's great to see already so many people have joined us. That's fantastic. And I think we're coming in thick and fast still, John and Phil. Fastest finger to let everybody in, I think.
I'll deal with that, Kerry.
I love it, absolutely. Oh, brilliant. We'll make it a straight start immediately, I think, because we've got a jam-packed session to get in, and we really want to welcome lots of quick Q&A. But hi, everybody. My name is Kerry Holden. I'm in my day job, I'm the Deputy Director for Infection Prevention and Control. In my other job, I am the Vice President of the Infection Prevention Society, and it is an absolute pleasure to welcome John and Phil today as a part of IPC Partners to be doing this co-hosted journal club. John, Phil, do you want to introduce yourselves?
Yeah, hi everyone, good afternoon or good morning, depending on where you are in the world. My name's John. I'm the Director of IPC at Guy's and St Thomas's, and looking forward to this journal club today.
Thanks, Kerry. Thanks, John. Hi, everybody. My name's Phil. Good morning, good afternoon. My day job is I manage the infection control service at Oxford University Hospitals, and then I'm one half of IPC Partners and delighted to collaborate with the IPS for the second time.
Fantastic. And we've got a really exciting topic today. We're steering slightly outside of John's and Phil's comfort zone, I think, if anyone's read their amazing their blogs about qualitative research. So we're trying to make infection prevention. We wasn't sure about this live or or a live for our frontline healthcare workers. So really great to be looking at this today. And I'm going to embarrass John before because I haven't told him this, but I'm going to embarrass him and say congratulations on your HIS Early Careers Award. Fantastic. We took me and only Jude were talking at clinical conversations last week about making sure we have good recognition for our colleagues in IPC. So I thought I'm going to completely embarrass you and say congratulations on that one.
Okay, I am duly embarrassed, but thank you, Kerry. It means a lot. I appreciate
Good.
it.
No, it's very well deserved. So yeah, before we get into talking about the articles, I'm going to pose probably a slightly difficult question, I guess, to John and Phil, asking because this one's really about how we engage and how frontline workers engage in IPC. So, the question to you guys: so what are some of the common reasons that you get or get faced with about why some people don't, and particularly healthcare workers, engage in IPC practices, or at least the good ones?
I think from my perspective, it's often competing priorities. I think if you think about how stressful, sometimes chaotic, that working on the front line to provide healthcare can be, then I think some of those priorities just mean that IPC gets pushed back a little bit. And I think that the challenge we've got is trying to make sure that it is at the forefront of people's minds. So they can maybe just take an extra couple of seconds to do something a little bit differently to try and adopt, good IPC practice.
Absolutely.
Yeah, good question. I thought you were going to ask us about the weather. That would be an easy question. It's been
That would have
hot.
been easier, wouldn't it?
It's
Yeah,
been
we
hot in
decided
England.
not to avoid
Shall
any
we-
questions about the weather.
Oh, sorry. Should we move on? Let's move on.
We can indeed.
Yeah, I completely agree. Competing priorities is crucial. I think the other thing is lack of clarity about exactly what we're asking staff to do. Very often, some of the guidance we've given, maybe historically, hasn't been very applicable in all scenarios, and maybe needs some adaptation to really work in a given clinical setting. So I think having that really understanding, mindful, and collaborative approach to generating local guidance that really works for people is a key part for me. And kind of related to that is inconsistency of advice. The thing that kills our service quickest is inconsistency of advice. If you ask one member of the team the same question, you get 10 answers. It just promotes this idea of keep asking the same question until you get the answer you want.
Absolutely, you've hit the nail on the head, and I think we all probably have sort of nervous breakouts of sweat when we think about guidance that came out on a Friday, and then we're having to kind of learn it, adopt it during the pandemic, and then go out and be that person that's supposed to be a full expert, and even though we only read it half an hour ago, and that's where some of that inconsistency comes from. And I think just to add to that, I guess it's what you're saying about the consistency, but understanding why we ask people to do the things that they do, particularly as you say, if they've got lots of competing priorities. The last thing, if people understand the why and the reason that they should be doing it, then hopefully it's more meaningful, but then hopefully it becomes a bit more embedded into the practice rather than it's just, oh, the IPC team have told me to do this, which is unfortunately what it can feel like at times. Brilliant. Oh, well, I'm just going to prompt everybody that there is obviously the Q&A chat function. Please do ask your questions. That's the great part of the Journal Club, is to generate that discussion. Obviously the chat function is there as well. But I'm no further ado going to hand over to Jon, who's going to take us through our first article.
Okay, brilliant. Thanks, Kerry. Really interesting preamble. Can I put in a request, folks? Please, can you make Kerry's life easier, because she's going to be handling the Q&A. And if everybody puts their questions in right at the start of the Q&A, it's basically impossible for her to read and filter. So if you have a question, please put it in as we go through and get the Q&A started, so that we can kind of go through it and try and be efficient in covering the questions we need to.
I appreciate that, Jon. Thanks for making my life easier.
No worries. All right, so let's jump in. Welcome to Journal Club. We love it. We're really enjoying how things are panning out with this regular event. And what we're aiming to do is to try and provide a bit of insight into a topical paper, generate discussion, that's crucial, provide opportunities for CPD. For us, it's such an important thing. We want to exercise our own and your critical thinking to look at the article and say, as much about what isn't there as what is there, in order to really interpret it critically. We're keen to build confidence so that you can go away from here feeling more able to go and read a research study and interpret what it means for you. I think we are already beginning to foster a network of enthusiasts and just occasionally have a little bit of fun. And just to note, all of the events are recorded and made available online after the event, so you can catch up later. So I wanted to start by telling you a story that happened to me many years ago now, that there was a new build ward that I was having a look around just to do it wasn't really a formal sign off, that had been done already. It was more a case of, let's have a look at this new ward. And it was beautiful. It was fantastic. We had a high proportion of single rooms than we'd ever had before. We had beautiful big bed spaces, lovely facilities, nice finishes to all the surfaces that were cleanable. And we said, well, where's the area for staff? Where's the staff room, both within the clinical area and a staff room generally? And the answer was, oh, we haven't really got space for that. We've kind of designed that out. Well, okay, but where do staff put their stuff, you know? So I think asking staff to deliver clinical care in general, but to go above and beyond their kind of normal role in a way, and begin to do what may be perceived as extra roles to do well, like the IPC work we're trying to ask them to do, in an environment that's just not built for purpose. That's a very big ask, and some of that came across in the articles that we looked at today. The article that I looked at was called "Infection Prevention Behaviour Among Nursing Hospital Staff Navigating in a Complex and Shifting Work Environment." So, as Kerry alluded to at the start, this is a qualitative article, and this puts me outside my comfort zone. It really does. I feel very comfortable in a quantitative research world where there's numbers and statistics, and we're trying to assess things that way. We're measuring things numerically, and that kind of works for me. It fits with my brain. Qualitative approaches are different. We're trying to answer different questions. Fundamentally, we're trying to get to the bottom of the why people do what they do. And I think as I've gone further into my career, that idea, the concept of the why people are doing what they're doing or not doing what they're doing, it is becoming increasingly important to me, because it's something that's quite foundational in the behaviour of healthcare staff directly influences IPC risks. And we can think of that in many different hues in terms of hand hygiene, environmental hygiene, antimicrobial stewardship, care of devices, the use of gloves. The list goes on and on, really. Pretty much everything we do that introduces an IPC risk to some degree is influenced by human behaviour. We already know, by way of background, that several working conditions will affect the frequency of healthcare associated infection. We know that bed occupancy classically is associated with infection risk, where higher bed occupancy equals more infection risk. Staffing levels, workload, the use of pool and agency nursing, and also the availability of materials at the point of care. For example, we can't really expect high levels of hand hygiene compliance when there's no hand hygiene product available at the point of care. So the aim of this study was to try to get to the bottom of nursing staff experiences and reflections on their working conditions and their own infection prevention behaviours. It was a qualitative descriptive study undertaken between April and December 23, so very much post-pandemic, and it was undertaken in 4 surgical wards and 2 orthopaedic wards in 5 Swedish hospitals. So it's quite a good range of hospitals included. The authors took a semi-structured interview approach in face-to-face interview focus groups for each of the 6 units. The interview was structured to cover several key areas. They looked at interruptions, they looked at patient room arrangements, they looked at psychosocial work environment, structural empowerment, work engagement, and work-related stress. Overall, the whole outcome of the study was boiled down to a single theme, which was navigating in a complex and shifting environment. I didn't find that distillation to a single theme enormously helpful. I felt the subcategorization was much more helpful, where they broke it down into the influence of co-workers and the workplace climate, the impact of interruptions and deviations in hygiene routines, and also access to adequate premises and materials and equipment. That's what reminded me of the story I told you at the start, with the new wall with no space for the staff to hang their coat. They also looked at the role of stress and high workload and how lack of time can lead to both conscious and unconscious deviations. So a couple of reflections on the findings of this paper. They talked about compliance as a herd behavior. I think it's a fairly useful term. We have a tendency to follow the crowd, we follow the leader, and clearly many of us are in leadership roles and have that role to play in order to help our organizations achieve strong performance. The feedback from the nurses in the groups was that it was sometimes easier to go along with the behavior, even if the participants disagreed with that behavior, rather than to challenge it. And that raises all sorts of questions about the culture and freedom to speak up and those sorts of things. In terms of what worked with motivating staff towards good behaviors, the staff wanted to hear more about the why, as well as just the how during training and education. It kind of made me think we need to be converting hearts and minds with the education work that we're doing, not just providing information. Participants felt that nursing staff are especially prone to interruptions due to the nature of their work. I think that's probably broadly true and matches my experience as well. The participants described what is, I think, a natural conflict between urgent patient care needs and reducing the risk of cross-transmission. If there's a real, genuine medical emergency situation, then yes, we can work broadly under the principles of infection prevention control, but we may have to make some significant compromises. Stress and high workload and lack of time, unsurprisingly, were commonly cited reasons for non-compliance. I found it interesting the way that the participants described work-related stress and how it's handled differently by some people, and that for some people, stress can be a positive, and we'll come back to that. So in terms of limitations and strengths, it was a nicely configured semi-structured interview and qualitative study. I like the analytical approach. The study participants were all nursing staff and selected from Swedish surgical units. So I'd question how generalizable these findings are to other settings and staff groups. In terms of scale, 27 participants isn't bad from a qualitative sample size point of view, but it really only represents a relatively small handful of views in the wider scheme of things. So let's have a think about some points for discussion that this raises. As I mentioned as we went through the results, it feels quite reductive to me to condense this study down to a single theme. I didn't find that personally very helpful. Providing staff with sufficient materials and resources is necessary but not sufficient to achieve safe IPC behaviours. I mean, I appreciate that's a bit of a truism, but I think that really is true. To provide staff with the materials they need, let's go back to the hand hygiene dispensers. If they're empty, staff can't possibly achieve high standards of hand hygiene. If they're full, then that doesn't necessarily mean that they will. Participants introduced the idea of positive stress, and this might be controversial for some, and I think it does depend how you define stress. There is certainly evidence that we need some degree of pressure oversight to reach a performance zone, but I think most would say if that steps over a boundary and becomes defined as stress, that's never a good thing. So I think part of this may be the way that this issue was being described. Left with questioning, how would culture and context of IPC in an organization influence perceptions from frontline staff? I think it's probably true that where you go in the world, infection prevention control is structured really, really very differently and plays a different role in the hospital. I'm not too familiar with the Swedish healthcare system, so I can't comment specifically on that. But I know from my experience of other healthcare systems that doing this kind of work in a small number of surgical units would give quite a different set of findings, I think, in different parts of the world. I liked the recommendations. Well, I liked the fact that the authors made recommendations. It's always a good place to finish. And I thought some of the recommendations were interesting. So they suggested team training with opportunities for reflection and peer learning. Nobody's going to disagree with that. They talked about discussing risk-based decision making to staff before they come into contact with a situation where they have conflicting priorities, so that you can have some pre-thought about, well, what would I do in this scenario? How would I work under the principles of good practice for IPC while still delivering the urgent patient care required? We need to consider the complexities of the work environment and provide adequate resources and support, and organizational action is required to address, to the extent possible, the overarching issues of workload, staff turnover, and the physical environment. There's only so much that can be done with these issues, and much will depend on the wider healthcare system. But if there's no attempt at organizational action on these issues, that you're going to end up with a disenfranchised workforce whose top priority is not going to be IPC. So finally, what does this mean for IPC? Well, we certainly have more to learn about workplace factors that influence the behaviour of nursing staff, that's for sure. And I think don't underestimate the importance of the workplace environment, both in terms of the physical environment and the human ecosystem in influencing behaviours. And I think beyond that, influencing outcomes. We know that the biggest single determinant of delivering safe healthcare is good interpersonal relationships between teams. So, Kerry, with that, I'm going to hand back to you.
Thank you so much, Jon. Really great summary of that article. I haven't got any questions, but I'll let people have a think about it. And as they're having a conversation, oh, I think I've got something in the chat. Maybe have a look and see. Yeah, there's some comments been made about it'd be interesting to see if staff are more inclined to be more compliant with IPC practices dependent on their perceived risk of infection to themselves. Oh, interesting self-preservation concepts, isn't it? I think we have this challenge of quite often with glove use. I think I particularly have that challenge about glove use. Did the study take this into account?
Yes, I mean, this is a case in point really for the importance of behaviour and understanding what drives human behaviour in trying to influence good outcomes. So we know that self-protection is an incredibly powerful motivator for behaviour. It's something that's deep rooted within us. It's deep within neural networks. It's not something we can change, and it's just something we have to embrace. If you look at the kind of metadata on hand hygiene compliance, we know for a fact that very consistently hand hygiene after patient contact is always more compliant than hand hygiene before patient contact. I think I'd prefer it the other way around, because you really want to have that immediately before patient contact. That's when I really want hand hygiene, but that's driven by self-protection, because you feel like your hands are contaminated after contact with the patient. Did the article take this into account? It wasn't really a major theme that came out. Staff didn't really talk about self-protection or fear as a motivator of behaviour. I suspect if it had been done 3 years earlier, in early 2020, at the beginning of the COVID pandemic, then those themes around self-protection and fear influencing behaviours, for good or for bad, would have come through much more strongly, I think.
Yeah, and I think just to echo, I think there's another comment as well. Natasha's just saying that staff presence doesn't always work. Otherwise, I think we'd look at our vaccination rates would probably, in terms of amongst healthcare workers, maybe a bit higher. But I guess it's not the be all and end all. I guess in everyone's behaviours in supporting that.
Yeah, and I think to that point, it's a good point. Thank you. It's not always conscious. You know, we're not always at the front of our minds thinking, "Oh, I've touched the patient, therefore my hands are contaminated, therefore I must clean them now." And we're not thinking before we touch a patient, "Oh, there's a lower chance of me getting harmed here. I'm not going to do hand hygiene." I don't think it works like that. It's not as conscious. It's
No.
around unconscious decision making. That's the tricky thing here.
That's a really good point.
Without
Oh yeah,
sorry,
sorry, Phil.
Kerry.
No,
Yeah,
jump in,
just
Phil.
without giving too much away, that fear, anxiety, and self-preservation are themes that are identified in my paper.
They are indeed.
So it's interesting. They don't give too much away in terms of, where the fear and anxiety comes into it, whether or not it's to themselves, or I guess it is from a self-preservation perspective, but the impact on the patients as well. But I think in my paper, a lot of that was linked to COVID.
Yeah, absolutely.
Phil, you've just stolen your own thunder there.
You have
You've
indeed.
slightly spoiled your own plot.
Giving the spoilers.
All for the benefit of the discussion, Jon.
Love it. There's also in the chat as well, talking about Stacey mentioned what was the best leadership for those on compliant wards, and it really brings through, doesn't it, about having that strong management style, but it doesn't really, in one of my reading, it really allude to a specific leadership style other than it's strong on the agenda and it's part of the culture of practice. But Jon, I don't know if these are your ideas about the best leadership style for those types of environments.
Yeah, I mean, this didn't really come out in the study. It's not something they particularly looked at. They weren't really asking the question of how do we influence staff to achieve good behaviours. They were asking the question of why the staff feel that like they behave the way they do. So it was around the self-perception of their own behaviours and the drivers and the motivators for that. But in terms of where we have issues with the ward, I think from my point of view, the worst thing to do is to go in heavy and start throwing around figures and talk about the big implications of what happens if things continue. I think that's likely to drive disengagement and put distance between you and the frontline teams you're trying to influence. I think it's a case of very much sitting down, spending time, giving time, walking in the shoes of the teams that you're trying to influence, because they understand their roles a lot more than you ever will. So I think there's a lot of listening to be done, and then to come with them to co-design a solution. I mean, that sounds easy, doesn't it? I know
It
it's
does.
not. It's a good question though.
It is the ideal, and actually it reminds me of a piece of work I think Matt Mayo presented at one of the IPS conferences, where he looked at kind of including human factors, and he got all of his staff, I think, to have a camera and literally just take photos of things that were, where that I never use that bin, it's in the way, and things that would help people to navigate it through the perspective of those that were actually delivering the care. So it was a really useful and insightful way to try and kind of figure out those nuances that you might not necessarily consider when you're not using that environment all the time. Yeah.
Can I throw that one back to you, Kerry? I'd be interested to hear your answer to that question. Yeah. What do you think is the best way to approach?
Yeah, I think
what's the best leadership approach for wards that are failing with IPC?
Yeah, I mean, I guess I'm going to echo what a similar approach to you, and I think I've got it in my brain. King's Fund has something called autonomy, belonging, and contribution, the ABC, and I think that's how I always think about how if you're going to approach anything, you need to empower those that are using those spaces and delivering the care, and bring them in that journey, that sense of belonging, doing that co-design work, and then getting them a chance to contribute. So getting them, staff that are actually doing the care and the practice to be able to actually design the change and be part of that continual improvement cycle, rather than sort of someone turns up and telling them. So I always think of ABC, which is kind of linked to compassionate leadership. So if I'm thinking that type of approach, and don't come with the solutions thinking this is the way it's going to be fixed, be a listener, and take on what, and try different things, things it's not going to work, use your PDSAs all the time, and modify those behaviors and those practices. It's not going to fit, it's not going to work immediately potentially, but be on the journey with those teams. Yeah, that's my response.
While you were talking, nice response. Was it ABC? What was that again?
ABC, autonomy, belonging, contribution.
Okay, that's nice. While you were talking, I was thinking about something from the study that was a bit more relevant, in that the staff did comment on what they wanted from training for IPC. and they actively wanted to know more about the why, not so much less about the how, but not only the how. Don't tell me what to do, tell me why to do it, why it's important. And that probably is useful to have in your mind when you're going into an area that is having some challenges with IPC.
Absolutely.
And I think the other thing to note is that infections can be a bit of a canary in the mine, in that they could be a signal of wider leadership issues. And very often you see a kind of co-correlation of different infections popping up in the same area, which suggests that there's been a dip in practice across several domains and not just IPC. So there may be some work to do across the organisation to think about what else is going on to support that area.
Such a good point. Yeah. Some more questions in the chat actually. Catherine has asked, were there any significant differences between the individual units? Just wondering about individual ward unit cultures, leadership styles.
Yeah, so this was all surgical units in Sweden. I think there were a couple of orthopedic and a couple of general ones. I can't quite remember exactly which ones they were now. They didn't go into any demographic comparison between the ward areas. So that's a good question and a good illustration of something that isn't in the study that might help us to interpret it. I suspect they would have been, and I think it was four or five different hospitals as well. So it wasn't all in the same centre. So I suspect there would have been a bit of variety of the setting in which where they were asking the questions. And that's helpful in terms of generalizability. But I do think there is a generalizability issue with this study in that it was in one country and in one context.
It would definitely be interesting to see things like areas like A&E, ED departments where they've got that kind of that stress of interruption I think is consistent, and it'd be interesting to see what their observations were. And then the other areas like intensive care and hematology oncology where that risk is probably more in the forefront of consistency, where if the risk of infection is probably is constantly a part of their culture and practice. It'd be interesting to see that sort of how that might alter those perceptions in those particular environments.
Yeah, good point.
Karine, also you've asked about compliance tends to be more effective when staff feel observed, don't you think?
Yeah. I mean, that is true. But the observer bias or Hawthorne effect is absolutely true. People do behave better when you're watching them. It's true of small children. It's also true of adults in a clinical environment. However, we can't observe people 24/7. Even if we put a video camera on them, it actually doesn't work. Even if you have an observer there for extended periods, there's some nice studies with hand hygiene observational data that shows that the observer bias diminishes over time. So the longer you watch somebody doing something, the less it influences their behavior. They kind of get used to being observed and they kind of revert to the mean. So I think to achieve meaningful practice, we have to get people to change their behavior, even when they're by themselves, even in the middle of the night.
Absolutely.
I think you meant the IPC police, John, when you talked about the Hawthorne effect, didn't you?
Yeah, exactly. Do we want to be that? Do we want people only to do something when they see the blue light coming?
Absolutely.
Yeah. Just really quickly, I was in hospital for some care recently, and somebody was taking some blood and they wiped my skin just with the faintest of glances, and I just explained the need, why you need to do the scrub and the crosshatch technique, etc. And they actually really appreciated the advice. They just said, I've not been trained to do it. So it does show that people might be doing things incorrectly because they haven't been taught how to do it. And if you can kind of effectively challenge in the right manner, then you can make a difference to practice.
Yeah, absolutely. I think that was interesting in this study actually about that herd behavior, and I guess that can influence for good and not so good at times depending on who you're observing in practice, I guess. And maybe we need to tap into when it's positive and when you've got those good role models out there, and how those, we often have champions, don't we, in our IPC practice, but maybe those are the herd behavior people that we need to be pushing out there to copy. Colette mentioned about corridor nursing, and what are your thoughts on maintaining IPC precautions in this, obviously, this environment that we don't want to be utilising? Assuming Sweden is fortunate not to be in this position.
Yeah, we shouldn't have it. Simple as that.
Absolutely.
It's not good. It's not good for patients. It's not good for staff. Not good for the future of the NHS. But clearly, I guess there are reasons why in extremis, it's a necessary evil. And I think it's a really good illustration of some of the things that came out in this study, and the perception of occasions when we simply physically can't achieve what we would consider to be best practice compliance or delivery of IPC standards, because that would introduce direct patient harm. So I think the most useful thing to come out from this study was to have teaching sessions or scenario-based education with staff where you're already working through those issues before they come before you're confronted with them in reality, because that way staff can have time to think about, well, okay, what would I do this? Why would I do this? What's the most important thing to get right in this scenario? So in terms of corridor care, it would be interesting to run a simulation with some ED staff. How is it different to deliver corridor care as opposed to care in a cubicle? And where are the key infection risks that we can prevent spread?
Yeah. I think that sounds like a nice research proposal for whoever wants to do that amongst one of our listeners. And actually, thank you to Graham, who's kindly shared actually a link to the work they've conducted about the threat of COVID infection alone didn't influence staff adherence to hand hygiene PPE usage. So they're even generating more articles to go and have a look at. So thank you for sharing that, Graham.
Interesting. I'll have a look at it during the chat. I wonder at what point of the pandemic that was, whether that was early days or whether that was later on. I think now that would be absolutely true, but interesting. Yeah.
It would be, wouldn't it? I'm conscious we probably, Phil, we probably need to get to you and your next session, but there's some more points in the chat, so please do feel free to keep adding. We'll come back to them because they are very nicely aligned, these two papers, so I suspect similar conversations will be generated. So do keep adding to the chat, and I'm going to be quiet and hand over to Phil.
Thanks, Kerry. Just checking you can see my screen.
I can indeed.
Excellent, thanks. It was a great discussion, and it's really good to hear so many people's different experiences and sharing research as well, which is what Journal Club is all about. So I don't know if John's stolen my thunder, or I'm going to try and steal some of his back, but I'm going to talk about another qualitative study. As Kerry said, we're right out of our depths here, John and I. We're more into crunching the numbers and looking at infection rates and looking at patterns and statistical analysis. But this paper was looking at a midwife's experience of infection prevention control. There's a qualitative descriptive study published, of course, in the Journal of Infection Prevention in September last year, I believe. So why did I choose this paper? I'm trying to test myself and get out of my comfort zone a little bit more, to read more qualitative research and more qualitative studies. I think in my time in my current role at Oxford, I've really understood more about the challenges and the barriers that people face to implement good IPC practice. So I'm just trying to understand what it is about unpicking human behaviour and how those things can be overcome to support optimum delivery of IPC in patient care. I think as well, I was interested that it's focusing on the midwife or midwifery area of nursing, given some of the things that we've seen in the press and some of the investigations that we've seen with some midwifery-led departments in various hospitals across the UK. So I was really interested to see how those staff, which we think are under a lot of pressure, well, they are under a lot of pressure, but are particularly in the spotlight at the moment with various inquiries, investigations going on, what their perceptions of IPC was. And also something I've learned more recently as well, but this idea of thematic analysis and how you can get some really valuable information and themes out from qualitative work. So that's why I chose the paper. So the paper essentially set out to do something quite straightforward, which is understand experience, the barriers and facilitators when adhering to infection prevention control. This was done through semi-structured interviews that were done with 10 different midwives at a hospital in Ireland, and they used that data to form a qualitative descriptive study. They set various different parameters for people to be included or be in the conclusion criteria, but these were quite straightforward. They were wanting people to be national nursing and midwifery registered and at least have 1 year of experience. And those interviews were done over the phone. They were recorded, they were transcribed, and then they were analysed using this thematic analysis by Braun and Clark. Just briefly, this is how the Braun and Clark thematic analysis is carried out. So you conduct your interviews, you familiarize yourself with the data, maybe listen to it a couple of times, then you start to do your data coding, then you start searching for your themes and your patterns, you review them, you define and name them, and then you produce your report or your publication. So it's a nice kind of start to finish in terms of how you work through your thematic analysis. And I thought this was a really interesting bit just to share with you from the paper, the types of questions they were answering. So it's a semi-structured interview. So these questions were given as a guide. They didn't necessarily need to answer all of them, is my understanding, but they were able to move around a little bit as well. I was more interested in some of these questions kind of towards the second half about what's influenced you to revisit infection prevention control guidelines, if you have, and then what facilitates you to implement and what prevents you from implementing. So a real kind of interesting insight into their perspectives of infection prevention control and the facilitators and barriers. So in terms of the way that the results were presented, from the analysis they did with the Braun and Clark thematic analysis, they identified two different themes, one being the seesaw for equilibrium, and then one for the back to basics and learning on your feet. So I'm going to talk about them separately and just run through a couple of key points. I think it's worth saying that there was some more themes captured, but I thought for this discussion, I would pick out the ones that I thought were most pertinent. So I think the first one really kind of ties in really nicely with the seesaw for equilibrium, and talking about how it's a need to find a balance between the demands of everyday uncertainty, demands and uncertainty of everyday practice and the desire to practice safely. I think when we're in a highly emotionally charged, stressful, challenging environment within any element of nursing, but maybe particularly within midwifery, then this balance is probably very pertinent. They also expressed the difficulty to balance the ability to adhere to IPC guidelines when performing some of the more challenging elements of their role. So night duty or working long days, as well as some of the physical demands. And I think this really resonated with me. You know, if we're thinking about how we can put IPC policy into practice and how we need to be mindful of some of the demands on our staff, particularly when they're working in these busy environments, but they might be working these busy environments in unsociable hours or part of, 11 hours into a 12-hour shift. So that's a big challenge, which I think resonated with me. And also then, dealing with the one's workload and balancing workloads contributing to behaviours deviating from the IPC guidelines in the clinical practice setting is another challenge as well. So lots of different elements there identified within that first theme. The second, with this back to basics theme, which was identified from the analysis and learning on your feet, there was a frustration in the paper about having to deal with other disciplines who thought about this culture of blaming the midwife when matters relating to IPC were not put in place. And I think for me, that really strikes a bit of alarm bells that people are blaming midwives when IPC policies weren't put in place or IPC practice wasn't put in place. And when we should be in a no blame culture, unless there is clear blame to be attributed to a risk. The also came up, so the idea of this old and not fit for purpose. I think, again, this is something that is out of our control from a human behaviour perspective. So how do we develop good IPC practice when we've got a failing estate or our estate isn't fit for purpose because we've got not enough side rooms or not enough spacing between our bays or our mums or expectant mums. So, this is kind of a challenge outside of the human behaviour side of things. This next one was really, really interested me, but this idea that there was an overuse of some visual cues, particularly posters. The participants talked about potentially kind of being overstimulated by them and the overuse, and that actually using too many posters means that the message is diluted. And we rely on, educational resources like posters a lot within IPC, don't we, when we're talking about maybe hand hygiene or donning and doffing, or disposal of waste. So is there maybe something to be said here about simplifying our messaging or making it less and more impactful? And the other thing was I think we see this all the time within IPC, this idea of a reactive rather than a proactive approach. And, you know, where is the role? I think there's a big role, sorry to say, about IPC being at the forefront of the discussion to make sure that the responses are proactive rather than being reactive when we're responding to maybe an outbreak or an incident. Just briefly before I go on to the kind of key takeaway points for discussion, similar to John, really, it was an even lower number of participants compared to John's study. So it's only a handful of views, and they're all from the same hospital in the same part of Ireland as well. So it'd be really interesting to see if those findings were generalizable in other hospitals outside of Ireland and expanding the number of participants as well. So what does this all mean for IPC? Well, I think the first thing is to say is that there's clearly challenges in the delivery of maternity care whilst maintaining IPC guidelines. And there are lots of external factors at play, such as working patterns, the environment and resources available to impact how we adhere to the guidelines. I thought this idea of visual overload was something that really kind of hit home with me. I think even in my own organization, we have a lot of posters. Can we think about making our messaging more concise? Does maybe less of it mean more? I think, you know, when you walk into a ward in my organization, you see the IPC notice board. It's actually really great for me to be able to see all of these different strategies, campaigns, good work that's going on from an IPC perspective in that central position. But then how do we make sure that that's impactful across the rest of the ward? How do we make sure that, you know, our hand hygiene posters are appropriately placed and our waste disposal posters are appropriately displaced? And do we have too many of them? Do we need to make it more concise? The other thing which the authors kind of fed out in terms of what these themes mean is that the supportive mechanisms around some of the kind of educational and collaborative mechanisms of IPC are really, really important. So this idea of having a buddy or a huddle and kind of behaviour focused education, all being supported with management, are really crucial. And also the element of COVID came up in the discussion as well. And was there a kind of narrow focus on certain aspects of standard IPC precautions, which led to the neglect of others? So is there maybe a way for us to refresh our guidelines post-COVID? I think that there was a bit of a guideline hangover from COVID, and we were all experienced the issuing of guidelines late on a Friday afternoon and, you know, trying to rush around and adopt them in actual clinical practice. But does that mean that we're maybe more fixed on certain elements of IPC and we've let others fall by the wayside? I thought that was a really interesting finding. And of course, you know, how do we manage IPC safe care, which I really like that phrase as well, IPC safe, when we're dealing with the challenges of a busy, emotionally charged and often a stressful working environment. Finally, these perceptions and motivators for guideline adherence were maybe some of the wrong ones. Fear, anxiety, and protection. I think the professional integrity is a good one, and that's important. But how do we ensure that people are doing this more routinely and they're not worrying about the consequences so much that they're not doing things, they're actually thinking proactively and thinking, I need to do this because it protects the patient and delivers safe IPC care. I've already talked a little bit about COVID and guidelines. And then the last 2 points, which I think is a really nice way to try and finish, is this idea of how all of these themes that were identified within the paper can be supported by effective education, training, and communication. And I think that's really true, isn't it? We talk about how important education is within infection prevention control. And I think that these types of things make a real difference to some of those themes that we've already talked about. Making sure that people feel supported, making sure that, you know, they can make the right decisions and they can be informed to do those risk assessments and ask themselves those questions when they're delivering care. And the other thing as well, which the authors pointed out in terms of what might speak to those themes, is this role of an IPC champion. Having somebody who, I think John talked about it really nicely, building a relationship with people in the clinical environment. So you're able to kind of break down some of those initial barriers and call upon them when you need advice, or call upon them when you've got a predicament or an incident, and feel like you're supported Obviously, we need to make sure that the resources available there and people have time to be able to do that. But I think that within IPC, what this paper talks about in terms of some of the complexities of delivering good IPC can all be supported by effective education, communication and training, which can be effectively facilitated by IPC champions. Okay, I'm going to stop sharing and I'm going to hand over to Kerry.
Thanks, Phil. I think already you've got some observations of similar experiences. I think Jane in the chat has said that even when designing and planning new facilities, the people actually who are going to use the building are rarely consulted, and the ergonomics is sacrificed for other agendas. So what's the kind of procurement, like cost saving value, and the value of the impact of that sometimes doesn't necessarily mean you aren't going back and changing it down the line, aren't you? And then investing of some of that money that you probably could have spent it in the first place, making it right and engaging the right people. So yeah, thank you for showing that observation, Jane. I think a lot of us, unfortunately, have experienced similar things. It's still strange that even to this day, I still find projects that IPC should be all over. It kind of lasts to the minute and realise, oh, we anyone thought about writing infection prevention? And Jane, you've also added a comment about maybe we need to look at other industries actually, that some safety work around road systems, about visual overloading with signage, which I thought was a really interesting observation about, because we do like a poster, don't we? Infection prevention, a laminated one as often is normally what we get digged at as well. But it's interesting. I was in doing some had some feedback about kind of hierarchy of interventions when you're trying to change behaviours, and we look at there's a really good a lot of us use SEEPS tools, which is a systems engineering for patient safety framework that's linked quite nicely with the patient safety incident sort of new approach framework in England. And what was interesting, I think posters and training was the kind of the lowest impactful sort of, it depends on how your training is being delivered, but was sort of the lowest impactful in changing behaviours. And interesting, one of the observations was how we use technology, and particularly some of our IT systems, to try and direct the correct behaviours. And they said actually now what's become the newest on trend thing is make an alert for it, because if you put an alert, it'll make someone do the right behaviour. And now we've got this alert fatigue where we've just got pop-ups coming out left, right and centre. So it's interesting that even in the kind of, as we're evolving in human factors, we've now got the new things that's supposed to be helping, and now even becoming another visual overload and just not making the impact that we would like it to do. So yeah, definitely Jane is, oh, that's helpful, having a partner that's a human factor specialist. that's probably very helpful and very useful to have in your family when you're trying to change behaviours.
Just on that, Kerry, I remember.
Yeah.
Yeah, I was just going to say, one of the things that I've heard Martin Kiernan talk about probably a decade ago now is this idea of maybe trying to embed human behavioralists or human behavior science within IPC, which I think is a really great suggestion. I think, to be able to thinking about how we make it easier, how we make it simpler for people to adhere is a really important thing. I think, we can write the best policies and come with the best intentions, but actually we've got to be able to make it manageable for the people on the floor delivering the care to be able to adhere to it. So I think that's a great suggestion. Maybe that's the future.
Maybe it is. Maybe that with the new future IPC practice. I know at the moment I'm doing my masters in patient safety and quality improvement, and I'm finding it's that more generalist approach to those sort of methods and approaches are helping me in my IPC journey. So definitely worth widening that scope out beyond sort of what feels like the traditional, let's try and train people up, and even just looking at how your training methodology is. Let's look at simulation, as Jon has already alluded to. Could we do war-based sims and things like that often tend to be a bit more realistic of the world environment that they're living in. It was interesting actually, Phil, when you mentioned about guidance, and it's make me something I try and challenge myself, and I should do better at it. But does our guidance actually is it pragmatic in the real world? Because we always often send our guidelines out, don't we, to all these expert groups to give us the opinion of what the best evidence is in the practice, but do we actually give it to the people who need to go and translate it into practice? So that's always my challenge to myself, and I'm always bad at doing it. So I'm going to make sure I do that going forward.
Yeah, I couldn't agree more, Kerry. I think it's got to be able to be implemented effectively, and I think that it's that policy into practice, isn't it? I really like that phrase. So I think that is there scope for maybe involving more people or a wider community in the development of these guidelines? I think we're there to provide the expertise and the knowledge and kind of the evidence behind the why, but what does that look like in the real world maybe? And how can we make sure that, do we look at our guidelines differently and say that if we can make them more accessible, if that's the right term, does that mean that we get kind of more uptake and implementation of them, as opposed to thinking, well, that's what the guidance is. If you don't like it, tough.
Yeah, absolutely. I think that's how everybody comes across, unfortunately, at the moment. Ian's
Can I
added.
can I
Oh yeah,
just
jump
can I
in,
throw
John.
something in on the guidance one? I saw a really
Yeah.
good talk. I think it was Hugo Sachs who presented like a visual overview of a guideline, and he presented a big sort of A4 piece of paper, and then he drew a much smaller jagged box within the A4 paper. And the point was, we have a huge amount of information in a really comprehensive guideline that nobody ever reads because it's far too long. If we were to crystallize it into 20% of what it was, could we get across the critical information to deliver safe care? And I thought that was a really interesting idea of whether we could completely take a novel approach to guidance, forget the heaviness, keep them really simple, almost like guidance on a page.
Absolutely. No, I definitely would agree with that. Interesting, as the talk Sarah's mentioned about what about incentivization. I think there's lots of offers, money, chocolates, coffee, time off, and certificates. But it's key critical bits of the ConV model, isn't it? A lot of us are using those sorts of human factors approach now, and ConV does look at positive reinforcement of some of those things. So there is probably a part to play in that. Absolutely. Nick
Kerry,
has. Oh,
Combi,
yeah. Yeah.
Combi. I know what it is. Not everyone will.
Oh, sorry. So this is different ways in which you can influence behavior change. It gives you a kind of a model and a framework approach to kind of change behaviors in practice. So it's I don't know, John, if you wanted to add more to that.
Well, it's capability,
Yes,
opportunity, and
there you go.
motivation. So those are the
There you
three
go.
things that combine to affect behavior. So capability, opportunity, motivation to affect behavior.
Yes,
And I
thank
think
you.
it's quite a nice model, and it kind of pulls in this idea about visual cues alone being insufficient and not very helpful. If they're implemented as part of a framework approach, then they can be helpful to influence behavior.
Absolutely. So I was just looking at Nick's asked the question, do we need to lower our expectations of our staff?
I guess that's
Who wants to answer that one?
Hi Nick.
Yeah, hello Nick. Give us a
Yeah.
complicated one, mate.
I don't think we should. I think we're ultimately coming with patient safety and effective IPC care in place. I think that we might revisit our guidelines and try and potentially make it more accessible or more achievable or implementable, whatever you want to talk about it. But I think in terms of what we're talking about with our standard infection prevention control precautions, I think that we should ensure that our staff are able to understand them and get involved with those as much as possible. Otherwise, I think we start to diminish the kind of role of the IPC nurse. If we're going to stop losing those kind of standards and precautions that we've put in place because they're based on really good evidence and they've been, adopted and routinely ingrained into our healthcare for such a long period of time, then, if we stop doing that, where does that leave us, I guess?
I love it. Nick's got great response.
Yeah, it was a great response. But can I just throw that back in a slightly different way? So rather than lowering our standards, is there a way that we can reasonably and safely ask less of people? So I think that policy condensation, I'm not sure that's even the right way to describe it. Making a shorter policy, like what a policy on a page, might be an example of that. We're not lowering our standards. We're trying to maintain the high standards of IPC, but we're delivering that in a way that fits better in the workflows of staff, is easier for them to access, and more straightforward for them to implement.
Absolutely. Yeah, we shouldn't someone said, let the perfect be the enemy of the good. I like that. That's a really nice. Thank you for Sarah for sharing that. Yeah, and there's some really nice comments, and people have shared some fantastic work they're already doing. Looking at Lisa's mentioned about in Wales have involved a behaviour scientist in new innovations around reducing CDIs and BSIs, involving the shop floor care workers. So there's probably a really good community of practice that's coming out there, and actually maybe the Infection Prevention Society because something to host some of these really good examples about how you've engaged more of a human factors ergonomic approach to supporting behaviour change. So maybe Jude, I know is on the call, so maybe Jude, you and I can have a think about how we might be able to help sort of share that really good practice that's out there. Yeah, just seeing if there's anything else that we should have a look at. Carol's mentioned many of the DRIP resources cover critical guidance points, guidance on the page. Look at that, giving the shout out for the IPS resources there. Thanks, Carol.
Policy on a page. I really like
Absolutely,
that.
on a page. Yeah,
Absolutely
maybe
brilliant.
we need to change our approach, don't we, to some of these things. So thank you. Yeah, key messages can get lost in policies that no one reads.
I mean,
Cool.
maybe if we're going to take something out of this, this is our next step, is that we get our guidelines to, be easier to be understood and implemented, and that you break them down into maybe a language or, a concept or a form where people can take a glance and go, right, I know I'm coming to work today, and these are how I'm going to adhere to my IPC kind of guidelines.
Yeah. And then taking that one step further as well is then actually when you go and apply it, can you actually apply it to the environments you're working in? So, but a classic thing I heard the other day when Mike Weinbrunn was talking about lobbied side rooms, and he was talking about, obviously we tell everybody don't put anything around sinks are just for hand hygiene, but then when you go in a lobbied side room, there's no surfaces, no worktops to put anything on. So what's the only flat surface you've often got in those spaces? It's often a sink. So we often then put the patient's jug on there and balance all the other bits and pieces whilst we put our PPE on. So yeah, you can have a practice and then making sure actually, that guidance is really, really, critically concentrated into what it needs to know, what you need to know, but also you can go in a way and actually do it. So yeah, definitely a good challenge to set ourselves there, Phil. Yeah, where's Sophie from my team actually said we've got something so CDIF in a nutshell. So it's just one page teaching resource that you use on the go. So it's hopefully kind of complements what you're doing on the ward-based training.
We do an advance actually for certain organisms. So again, just trying to understand what the considerations are with MRSA, for example. If you've got a positive patient, this is what you need to do with them. This is what it is. This is a little bit about how it's transmitted. These are precautions. So yeah, great idea.
I was just going to go back to this idea of learning from other industries and ask you whether either of you have had any good experience actually of learning from other industries around how we can influence behaviour to reduce IPC risk.
Interesting, isn't it? Because I mean, as often aviation is often kind of the one is that critically gets looked at, isn't it? But it was interesting. I was doing some reading about it, and they were saying it's not always as translatable necessarily, because often that, perfect in that first article, you've got interruptions. I doubt that the pilot's going to get those sorts of same interruptions that a nurse or a medic might face while on the ward. So sometimes I don't know if it's truly translatable to healthcare, but obviously some of the principles, and particularly looking at a systems approach, I think in terms of how we look at incidents and incident prevention is definitely a way we should be looking forward to it, rather than we're very good at doing root cause analysis, which often looks a bit single focus, isn't it? So this kind of new approach to doing more of a kind of a human factor system approach to learning is definitely one I would take from aviation. And I think in factories, don't they, lean is often a way of coming forward for approaches to quality improvement. So I guess there's lessons we can take from. I'm going to put it back to you, Jon. Have you got anything specifically that you've learned from?
So I heard an ex-exec from the airline industry come and talk to us about behaviour change, and actually something he said, not about the aviation industry in terms of the commercial sector, but military aviation was quite interesting. I remember he said on an aircraft carrier, rank is suspended on the deck. So at the business end of where the danger lies and where they really need to get it right, there is no rank. So the lowest ranking person elsewhere on the ship can do exactly what they want with the highest ranking. I thought that was quite interesting for some of our areas where perhaps hierarchy may get in the way, maybe a traditionally minded operating theatre, for example.
Yeah.
Can I just give two recommendations? So I read a fantastic book by somebody called Matthew Said called Black Box Thinking, and he talks about different ways different industries have talked about small incremental gains. But the third thing he talks about is the aviation industry, and just that, Jon, talks about how nobody wanted to challenge the pilot. And now that the air hostesses or junior members of staff can challenge the pilot. So that's a really good book. The other one is Surrounded by Idiots. So this is more talking about how you can effectively communicate with people who've got different motivators. I don't know if anybody on the call has done kind of the disc profiling, where you put yourself into a different color depending on what your kind of own commercial, your own individual communication style is. But it just talks about, you know, if you're dealing with somebody who is really outspoken and loud and vibrant, how, and you might be a shy, reserving flower, what is it, the things that you can have in the commonality to be able to you have a good conversation and to be able to kind of break down some of those barriers where you think you might communicate effectively, but there are probably things in where you can meet in the middle and then communicate effectively that way.
Great recommendation there. Thank you, Phil. And I think I'm going to leave you with some food for next time, I think, for hopefully get people's appetites wet for a next journal club.
Yeah, thanks, Kerry. So yeah, just a final message from me. This is our last journal club for a couple of months now. Jon and I are going to be taking a little bit of rest. We're really grateful to all the support and all the people who've attended previous journal clubs. I think we've done 26 or 27, so really proud of that. And it's great to see so many people on the call who've been in previous journal clubs. We're delighted to have partnered with the IPS, so thank you, Kerry. Our next journal clubs we're looking into now September, where we have Dr. Naomi Oki, excuse my pronunciation, will present in September. And then we've got another partnership with the IPS in October, and then one with HIS, and we'll be sharing more details of that with you in the future. But yeah, thank you all for listening, and we look to see you soon. Have a great summer.